Welcome, everyone. Today, we're diving into a comprehensive explainer on the treatment of leprosy, past, present, and future. Now, the introduction of multi-drug therapy by the World Health Organization back in 1981 was, quite frankly, an absolute clinical revolution. But we still face a pretty sobering reality today. The number of new leprosy cases detected annually has basically remained stubbornly stable for the last 15 years. So, as future leading dermatologists and medical educators, a superficial understanding just isn't going to cut it. You need a total, in-depth mastery of this chronic infection, from its early pharmacological missteps all the way to the biological frontiers of tomorrow. All right, here's our roadmap for this explainer. We'll start with the history of treatment, move into the critical evolution of multidrug therapy, tackle those real-world clinical issues, evaluate newer therapeutic agents, dissect the pivotal 2018 WHO guidelines, and finally, look ahead to immunotherapy and the future of global eradication. Okay, let's jump right into part one, the history of leprosy treatment. Early therapies like chalmoger oil were primitive, toxic, and, let's be honest, largely ineffective. So let's look at how things actually started to evolve. Picture this. It's 1941, and our first true rays of pharmacological hope emerge when Guy Fawkes uses IV Promin, a Dapsone derivative, at Carville, USA. Now, it actually worked, but man, it was incredibly toxic to give intravenously. This directly paved the way for Lowe and Smith in 1949. They successfully utilized oral diaminodiphenylsulfone, or DDS. This monumental step kicked off a 30-year era of monotherapy. Following that, Rifampicin was synthesized in 1959, and by 1962, clofazimine was confirmed effective based on evidence in mouse footpad responses. So let's really break down our first major player here, Dapsone. Administered orally at 1 to 2 milligrams per kilogram daily, it's extremely cheap to produce and has a fantastic shelf life. Now, here is a crucial examination pearl for you. Dapsone works by competitively inhibiting dihydrofolate acid synthesis. Specifically, it blocks the enzyme dihydroperitoid synthasase. While it's only weakly bactericidal, the real clinical catastrophe that hit in the 1960s was resistance. You absolutely must know that primary and secondary Dapsone resistance is directly linked to mutations in the FOLP1 gene. That's a high-yield fact discovered after the first reported resistance case in 1964. Oh, and always keep an eye out for classical adverse effects like methemoglobinemia and agranulocytosis. Next up is the absolute heavy hitter, rifampicin. Its exact bactericidal mechanism involves inhibiting DNA-dependent RNA synthesis by blocking RNA polymerase. You might be wondering, why do we give 600 milligrams only once a month for leprosy when we use daily dosing in tuberculosis? Well, it's because Mycobacterium leprae has an incredibly slow doubling time of roughly 14 days. This unique biology is what allows for a highly effective, supervised, once-monthly dosage. Just a pro tip, always remind your patients about the harmless red or orange discoloration of their bodily secretions and monitor them closely for hepatitis and flu-like syndrome. Let's compare two other classic antimycobacterial agents. Clofazimine is a brick-red, fat-soluble phenazine dye. It acts by blocking the DNA template function. What makes it so brilliant clinically is its high lipophilicity. It accumulates extensively right inside macrophages, powerfully inhibiting the intracellular multiplication of the bacteria. Resistance here is exceedingly rare, but at high doses, it can precipitate into crystals in the intestinal mucosa. That can cause severe, sometimes fatal GI complications, right alongside that notorious red-black skin discoloration. We contrast this with ethionamide, which inhibits cell wall synthesis but carries a significantly higher risk of hepatotoxicity. Moving right along to Section 2, the evolution of multidrug therapy. By the 1970s, it became painfully clear that health authorities urgently needed a new strategy. So, what triggered the shift? The 1981 WHO study group mapped out a very clear rationale for moving to multidrug therapy. Monotherapy was predictably breeding drug resistance and totally failing to clear viable bacterial persisters, especially in those heavy-load lepromatous patients. A combined arms approach was absolutely essential. By hitting the bacteria with drugs that have completely different mechanisms of action all at once, we could combat resistance, eliminate those stubborn persisters, reduce patient defaulting by lowering toxic side effects, and dramatically shorten the overall treatment duration. Now, this massive operational shift didn't just happen overnight. In 1977, the Bombay Leprosy Project, an NGO, boldly initiated the groundbreaking rifampicin, clofazimine, and Dapsone combo in the slums. By 1981, the WHO officially recommended MDT. Notice the psychological and operational evolution here. Initially, the rule was treat until smear negative, which, as you know, could take many years. A lot of leprologists were incredibly hesitant to just stop treatment while lesions were still visible. But by 1990, the evidence strongly supported a 24-month fixed-duration treatment, or FDT. Finally, in 1997, the WHO redefined multibacillary leprosy treatment down to just 12 pulses. And here is the exact pharmacological why behind that shorter timeframe. The crucial point is this. Rifampicin kills greater than 99.999% of viable M. lepra organisms with just 3 monthly doses. That's it. The 12-month FDT works flawlessly because rifampicin rapidly sterilizes the patient, completely breaking the chain of transmission. The Dapsone and Clofazimine aren't the heavy lifters for initial clearance. They act purely as a protective safety net to sweep up any rifampicin-resistant mutants. This is a classic Viva pearl, so definitely file that one away in your memory. All right, on to Section 3, clinical issues. Because as you all know, our job as dermatologists absolutely does not end the day the patient finishes their blister pack. Relapse. It's a formidable and frustrating challenge, and it typically hits long after treatment is completed. The major risk factors you need to look out for include a high initial bacteriological index of 4+ or more, an inadequate history of earlier monotherapy, and importantly, being Leprmin negative, which indicates poor cellular immunity. It's critical to understand that relapse is usually due to bacterial persisters simply waking back up, rather than true acquired drug resistance. This is exactly why we need prolonged clinical follow-up. You've got to diligently monitor for the appearance of new skin lesions or a significantly increased BI on slit skin smears. Post-MDT, your multibacillary and paucibacillary patients are going to present with completely different clinical trajectories. In MB patients, you'll face the frustratingly slow fall of the BI and the persistence of visible lesions, even though the bacilli inside those lesions are dead and harmless. On the flip side, in PB patients, you must be hypervigilant for a worsening of nerve function. This delayed response in PB cases can literally be vision-threatening and severely crippling if you don't promptly recognize it and aggressively manage it with systemic corticosteroids. Section 4. Newer agents. The pharmacological search is constantly on for faster, highly bactericidal agents to overcome some of these hurdles. Let's do a rapid-fire postgraduate pharm review of the second-line arsenal we rely on. Fluoroquinolones like ofloxacin and moxifloxacin powerfully block DNA gyrase, but you really have to watch out for adverse effects like tendinitis or even an Achilles tendon rupture. Tetracyclines like minocycline are bactericidal by binding the 30S ribosomal subunit, causing that notorious tooth discoloration. Macrolides like clarithromycin bind the 50S ribosome, potentially causing a metallic taste and confusion. And finally, Ansomycins like rifampicin work similarly to rifampicin by blocking RNA polymerase, but they give us a much longer half-life. Several mass program trials actually attempted to leverage these newer drugs to simplify treatment globally. ROM therapy, that's rifampicin, afloxacin, and minocycline, was tested as a highly appealing single-dose therapy for single-lesion PB leprosy, but it was ultimately withdrawn for complex operational reasons and difficulties with follow-up. There was also this intense debate surrounding universal MDT. The idea was a universal 6-month regimen for absolutely everyone to avoid misclassification errors in the field. However, experts rightly pushed back, fearing that a blanket 6-month approach would severely undertreat our heavy-load multibacillary patients. Which brings us right to Section 5, the 2018 guidelines. This brilliantly illustrates the modern battlefield, and it's the absolute standard of care you need to practice today. The 2018 WHO guidelines introduced a massive paradigm shift. Paucibacillary patients now receive the exact same 3-drug regimen, rifampicin, dapsone, and clofazimine, as multibacillary patients. They just get it for 6 months instead of 12. So why this sudden change? It's to completely eliminate the severe consequences of undertreating an MB patient who was accidentally clinically misclassified as PB by a health worker in the field. Adding clofazimine to the PB regimen provides that vital extra layer of bactericidal safety against relapse due to a diagnostic error. But what if you actually encounter real drug resistance, specifically rifampicin resistance? The crucial 2018 protocol dictates a mandatory, highly intensive 6 months of daily afloxacin or another fluoroquinolone plus minocycline or clarithromycin, alongside clofazimine. This intensive phase is then strictly followed by an 18-month continuation phase of clofazimine plus 1 second-line drug. This strict 24-month protocol is absolute gospel right now for managing drug-resistant cases and preventing any further mutations. Finally, Section 6, Immunotherapy and the Future. We are actively shifting our mindset from merely stalling the bacteria to actively clearing out the dead bacillary pools. Looking at our pipeline, we have some incredibly novel bactericidal agents. Bedaquiline is a tremendous high-yield exam point for you all. It uniquely targets the proton pump for ATP synthase, effectively starving the mycobacterium of its energy metabolism. But a word of caution for you clinicians, you must be highly aware of its ability to persist in tissues for long periods and potentially cause arrhythmias or prolong the QT interval. We're also looking at brodomiprim, a dihydrofolate reductase inhibitor, acting sequentially on folate synthesis, and fusidic acid, which prevents the translocation of elongation factor G during protein synthesis. But as I mentioned earlier, just killing the bacteria with antibiotics isn't really enough. We have to deal with the massive histological debris left behind. Immunotherapy in leprosy is all about utilizing immunomodulators to stimulate the host's own cell-mediated immunity. The therapeutic rationale here is that the large, persistent pool of dead bacilli lingering in tissues triggers severe, tissue-destructive delayed immune reactions. Think type 1 reactions and erythema nodosum leprosum. By actively boosting CMI, we help the host's macrophages digest and clear out this dead pool much faster. And the absolute superstar in this immunological frontier is the Mycobacterium indicus prani, or MIP vaccine. Clinical evidence strongly supports MIP as a powerful adjunct to standard chemotherapy. When you add MIP to the mix, you see a significantly faster histological clearance of granulomas, faster clearing of those dead bacilli, and a beautiful, marked reduction in the incidence of severe leprosy reactions. This is a total game changer because it not only improves clinical outcomes, but it dramatically boosts patient compliance and reduces permanent nerve damage. So let's take a step back. From the toxic, nauseating days of chamuger oil and intravenous Pramin, we've evolved into an era of highly strategic, multi-drug therapy and sophisticated fixed-duration regimens that cure millions. Now we stand right on the precipice of advanced immunotherapeutics like the MIPS vaccine. So, I leave you with this final provocative thought. Can the aggressive integration of novel pipeline biologics targeting ATP synthesis combined with MIPS immunotherapy to supercharge host cell-mediated immunity finally clear that persistent bacillary pool and eradicate Mycobacterium leprae from humanity once and for all? That is the ultimate diagnostic and therapeutic challenge for your generation of dermatologists. Keep studying, keep questioning, and I'll see you in the next explainer.